William Sutherland was in his last year of osteopathic training in Kirksville, Missouri at the turn of the last century. He had passed by a display case containing a disarticulated skull many times. One day while looking at the sutures, a thought occurred to him, beveled like the gills of a fish, indicating articular motility for a respiratory mechanism, meaning that the cranium was made to move. This momentary insight was to transform his life and the history of cranial osteopathy. Up until this time, the cranial bones had been considered immovable. Dr. Sutherland was fascinated by the possibility of a cranial mechanism that allowed for motion and could not put this thought out of his mind for years. After he set up his osteopathic practice, his inquiring mind led him to take apart his model skulls and delve deeper into his idea. If the skull sutures were capable of moving and breathing, then he would try to prove it. In school, he was taught the basic osteopathic premise that structure follows function. In this case, if structure follows function, then why would the sutures look movable if there were no need for movement? Dr. Sutherland was a persistent scientist and began experimenting with his wild idea on himself. He gathered together pieces of leather from baseball mitts, a football helmet, shoelaces, and pieces of rubber, and devised a helmet that he could strap on and compress different areas of his cranium. With the use of this helmet, he compressed the fourth ventricle of the brain and managed to stop the movement of his temporal bones. He stood on his head with the helmet on and practically passed out during some of his experiments. In other experiments, he compressed his cranium and felt heat in his sacrum, inspiring him to postulate a connection between the cranium and the sacrum. Through his long years of experimentation, he came to the conclusions that we now take for granted. The cranium does move and breathe. In terms of treatment, Dr. Sutherland advised delicacy and presence. He spent a part of every day in silent contemplation and said that the time he spent in the still silence was what gave him his insights into the cranial system. His touch produced dramatic results with people who were very severely injured and mentally handicapped. Dr. Sutherland inspired many osteopaths to continue the work he began, and his legacy continues to ripple out from that first insight he had as a student. These fascial sheets also transmit force in an anterior-posterior direction, as well as superior to inferior. The dura mater also forms the tentorium cerebelli, which acts like a tent separating the cerebrum from the cerebellum. The tentorium transmits force in a lateral direction. Dr. Sutherland termed the phrase reciprocal tension membrane to describe the function of the tentorium and the falx. As these membranes are connected directly to the cranial bones, their tension patterns have a great effect upon the movement of the cranial bones. The purpose of most cranial techniques is to balance this membrane system as well as free any sutural restriction. Next to the dura mater is a layer of delicate tissue called the arachnoid matter. Next to the arachnoid matter is the pia mater, and this layer of tissue follows the contours of the brain. These three layers of tissue are called the meninges and are free to move in relationship to each other because they float in a sea of cerebrospinal fluid. There are 4 ventricles or spaces in the brain that are connected to each other and the subarachnoid space. Hanging from the top of each of the ventricles are a group of capillaries called the choroid plexus. The choroid plexus filters the blood, and what they let pass is called cerebrospinal fluid. The cerebrospinal fluid circulates around the brain and spinal cord until it is reabsorbed by the arachnoid villi. Dr. Upledger, an osteopath and one of the many popularizers of cranial work, has hypothesized that as the pressure increases inside the cranium, stretch sensors in the sutures send an inhibitory reflex to the choroid plexus, which stops producing cerebrospinal fluid. When the pressure decreases, the production starts again. The increase and decrease of pressure is what is thought to drive the pull of the reciprocal tension membrane and the movement of the cranial bones. This is called the pressure stat model. Not all doctors agree with the pressure stat model, but the fact that cranial motion exists is the most important consideration to the practitioner. The movement of the cranial bones is described in terms of flexion and extension. These terms are based on the motion of the sphenoid. Flexion is when the top of the sphenoid moves anterior and the bottom moves superior. The movement of the rest of the bones is also called flexion, even though their individual motions are unique. During flexion, the whole cranium becomes wider from side to side and foreshortens from front to back. The entire flexion extension cycle takes about 6 seconds. Quiz. Question 1. The dura mater, A, encases the brain and spinal cord, B, secretes cerebrospinal fluid, C, is located within the arachnoid matter, D, is a dysfunctional movement pattern. The correct answer is A, encases the brain and spinal cord. Question 2. The mandible articulates with A, the parietals, B, the occiput, C, the frontal, D, the temporals. The correct answer is D, the temporals. Question 3. Which of the following is not part of the reciprocal tension membrane? A, the falx cerebrum, B, pia mater, C, the tentorium cerebelli, D, the falx cerebelli. The correct answer is B, pia mater. Question 4. The choroid plexus, A, distributes force anterior to posterior, B, distributes force laterally, C, filters the blood, creating cerebrospinal fluid, D, surrounds the cranium and spinal cord. The correct answer is C, filters the blood, creating cerebrospinal fluid. Lesson 3, Technique. Direct technique and indirect technique are two treatment approaches. With direct technique, you first evaluate range of motion for the bone. If a barrier is discovered, for example, in an anterior direction, meaning that the bone won't move anteriorly, then with direct technique you urge the bone in an anterior direction, engaging the barrier and stretching it until it softens. With indirect technique, if a barrier is found to be in the anterior direction, the practitioner follows the bone in the direction of least resistance, in this case probably posterior. After a release is felt, then the practitioner retests for motion and discovers that the anterior barrier is gone. So direct technique directly confronts the barrier, while indirect technique goes toward the place of greatest ease. Most cranial therapists discover that indirect technique is much more effective and safe. The application of indirect technique to cranial work is manifested in the technique called tracking. Tracking means following the motion of the cranial bones. As you follow the cranial bones, restrictions will release because of the fulcrum you are providing. Normally, the cranial bones are influenced by intercranial pressure, the reciprocal tension membrane, and muscular attachments. When the practitioner touches the bone, even with the 5 grams of pressure that is recommended for cranial work, a new influence is set upon the bone. This small amount of pressure is called a fulcrum. There are 4 possible outcomes as you provide a fulcrum: release, unwinding, still point, and no change. Release is when a barrier dissolves and the bone is able to resume its natural movement pattern. You will know a release by noting if any of the following occur: a lengthening or opening of the tissues you are touching, the area warms up or you feel a steady and strong vascular pulsation, the bone becomes smoother or wider in its range of motion, a more liquid feeling, an increased energy flow to the area being treated, a general relaxation of the whole body, fasciculation or trembling or twitching. The client's breathing pattern alters, becoming slower or deeper, or includes a yawn or a sigh, an emotional release, possibly weeping. The intent of performing cranial work is to facilitate a release. When you feel a release, wait for a little while to make sure it is complete before moving to the next technique. Another outcome to providing a fulcrum is unwinding. Unwinding is a change in the fascial tensions that induce spontaneous movement in the client's body. The movement can be large, the client's arm extending, or small, the client's neck rotating. The sensitive practitioner can let the body lead and support the motion that the body wants to make. Just hold on and allow the body to move. Upledger reports that during unwinding, many clients end up in the same position that they experienced in an initial trauma. Unwinding is the body's natural process of releasing restrictions, and if it occurs, should be allowed to continue. After the unwinding stops, both you and the client will notice a release has occurred in the tissue you are working with. Another outcome to providing a fulcrum is a still point. The best description of a still point is that the cranial rhythm comes to a stop. The practitioner will experience a still point by the cessation of movement in the palpated bone. This can happen spontaneously through the fulcrum, or can be encouraged by the practitioner placing a drag on the cranial motion. During still point, the entire cranial system will reorganize, frequently initiating a spontaneous corrective movement. When the cranial rhythm returns, it will be stronger and fuller. The wisdom of the body to heal itself resides in the still point. The final outcome to providing a fulcrum is that there is no change. Perhaps there are no restrictions to release. Another option is that the practitioner is not feeling the cranial rhythm, so cannot accurately assess when a change happens. If palpation of the cranial rhythm is difficult, lighten your touch. The mistake students most often make is to push too deeply. Due to the delicate hydraulic balances within the cranium, just 5 grams of pressure, or the weight of a dime, is all it takes to apply a fulcrum. The light finger pressure combined with the therapist's sensitivity to the cranial rhythm is what facilitates a release. Many of the cranial techniques apply this light compression, which loosens the sensitive reciprocal tension membrane, allowing it to unwind. It doesn't take a lot of pressure to effect a great change. And sometimes the touch is so light that the practitioner's intention is enough to initiate movement. In craniosacral therapy, presence is just as important as technique. It is very difficult to monitor the craniosacral rhythm of a client if you are not present and quiet inside. Any personal practice that enables you to quiet your mind and body will greatly enhance your ability to do cranial work. Remember that the movement of the cranial rhythm is occurring at a quieter and slower pace than the respiration and blood circulation. First, learn to monitor the blood pulse and the breath of your client so that you will be able to differentiate these rhythms from the cranial wave. The techniques that you will use have the generalized intention of accessing the memories held in the bones. It may be memories of trauma, of birth, of emotional problems. Any kind of pain and imbalance can be accessed through focusing on how the bones feel. They will talk to you if you are still enough to listen. Your client has shared with you her reasons for seeking out cranial work. Listen to the feelings under her words. Your most important intention is to be willing to be present, to feel with your alert fingers what her bones are saying to you through their dance or lack of dancing movement. No two people dance in the same way. Don't force your perception of how the dance ought to be onto your client. Just follow her lead. Be interested and alert. Know when to pursue a rhythm and when to let it go by. You will know by how you feel inside as you hold the bone. Learning the basic patterns of each bone can be helpful in knowing how to respond to the rhythms you feel. But just because a bone isn't behaving in the orthodox way, don't assume that this movement is wrong. Just be with what is and feel it move and shift. The ultimate healer is the body of the client. You provide the attentiveness and hands, and the client will provide the healing with the wisdom of her own cerebrospinal fluid as it ebbs and flows and interacts with the bones and the reciprocal tension membrane. You are simply providing a new vantage point for reorganization of patterns. Exercise 1. Many people it takes multiple tries to feel the motion. You can stay in this position for an hour if you need to. Just keep feeling and listening and trust that at some point you will begin to feel the rhythm. Lesson 4, the sacrum. The sacrum is located at the base of the spine. It articulates with the fifth lumbar vertebrae and the ilium on each side. The dural tube is attached to the anterior lip of the sacrum on the second sacral segment and free floats through the spinal column, then attaches at C2 and also to the foramen magnum. Because of this, both bones mirror each other's motion. Pull on the sacrum through the dural tube causes the sacrum to swing along a horizontal axis, the apex moving anteriorly during flexion and posteriorly during extension. Many other micro movements or deformations are possible, including side bending, as well as a circular motion where the tip of the apex of the sacrum moves in the circle. These are just a few of the possibilities, and it's up to you as a therapist to be present and feel each sacrum individually. Restriction in the sacrum can pull on the dural tube, causing dysfunction all the way up into the cranial base. A restricted sacrum can be the culprit in sinusitis, migraines, and other maladies that affect the cranial base, as well as the more obvious lower back pain. On the personal level, the sacrum houses a fiery energy and may also hold memories and trauma relating to birth, sex, and survival. Keep this in mind as you get still and connect to the sacrum, allowing it to speak to you. The purpose of the following techniques is to release any restriction in the client's sacrum and SI joint and restore a healthy, harmonious range of motion to the sacrum. Our first technique is called the sacral release. Get a stool or chair and sit next to your client at the level of their hips. Tell them what you're going to do and ask your client to raise their hips off the table, then slide your right hand under your client's sacrum and your left hand under the 12th lumbar vertebrae. Your hands should form a T. Again, ask your client if they are comfortable with this. Become quiet inside as you attune your breath to your client's. Notice anything you feel. Does the sacrum feel stiff or pliable? Is there a regular rhythm? Be patient. It will take you some time to sense the subtle motion in the sacrum. The more attuned you are to your own inner quietness and the more focused your attention is, the more clear the motion will be. Sometimes the weight of the body may cause your hand to go numb. In Dr. Upletcher's book, Craniosacral Therapy, he states that this numbness is okay and actually increases your proprioceptive sense by diminishing other distracting sensations. If your hand goes numb, you can keep working or stop and perform a different technique while your hand renews circulation. Also note that because your hand is between your client's legs, this technique may look invasive or inappropriate due to the close proximity to the client's genitals. Looks are deceiving, however, and the client will experience your hand more toward the back of their body and not close to their genitals at all. After you've begun to feel movement, there are 3 possible intentions. The first is to follow the sacral motion during flexion extension. For this, push your elbow into the table, using it as a lever to allow your hand to have greater contact with the sacrum. Let the hand melt and become one with the sacrum as you feel the motion. If there is a restriction in the motion, just follow it. The gentle, buoyant touch of your hand and your intention will create a fulcrum, causing the sacrum to reorganize and start to move in a balanced way. This may take up to 10 minutes. Be patient and keep following the motion until it is balanced and full. To encourage a still point, you would hold the sacrum a little longer in flexion, not using more than 5 grams of pressure. When the client goes into a still point, just wait. When the body starts to come out of a still point, it gathers energy. When the cranial rhythm returns, it will be stronger and fuller. The wisdom of the body to heal itself resides in the still point. The next possible intention is to use this position to evaluate restriction in the dural tube. As the sacrum moves into flexion, think about the slightest traction and extend your awareness up the dural tube, feeling for any restriction. To feel further up the tube, gently increase your pull. Any restriction in motion indicates a restricted dural tube. With practice, you will be able to sense how far up the spine the dural tube is restricted. The final intention for this technique could be to decompress the lumbosacral joint. Some authors believe that compression at the lumbosacral joint is an underlying cause of recurring cranial base restriction. To perform this technique, apply gentle traction to the sacrum in an inferior direction while your superior hand stays stable. Remember to use a maximum of 5 grams of pressure. Focus on creating space between the 5th lumbar vertebrae and the sacrum. Wait for a release to occur. If you perform this decompression, make sure to also decompress the cranial base, as the two are connected. Now we'll perform a modified sacral release. For this sacral T, keep your right hand outside the leg. Have your client lift their pelvis and slide your right hand under your client's sacrum, then place your left hand superior to the right hand to form a T. Again, become patient and wait for the sacrum to speak to you. If the patient has come to you with sciatica, sinus problems, or low back pain, then you may suspect the sacrum is being involved, but always keep an open mind, because low back pain could be caused by a sphenoid bone that is stuck on one side or a jammed frontal bone. You never know until you actually feel the rhythm under your fingers. Just as in any fluid mechanism, all the parts interact with each other. As you free up one part, you may free up others, or you may see more clearly where the problem area is and zero in more directly. You're solving a mystery and need to be very alert. The next technique is called the cradle. For this technique, sit at the side of the table, move the client's hand out of the way, roll the hip up and slide both hands so they are cradling the sacrum. This technique is used to monitor the sacrum's motility at a deep level. Your client's body will be providing most of the compression. By pressing your forearms into the table, you can move your hands into a more intimate